forgot at the break. I just wanted to clarify something. I was asked a question about the venous desaturation and what exactly that means and how that contributes to hypoxemia. Well, if you look at this slide, this is the saturation of the venous blood. Okay, imagine these numbers, instead of being 40 and 46, were 20. Let's say the oxygen here, instead of being 40, was 20. Okay, but if you're starting from a lower baseline, then it may be harder to oxygenate that blood and get it up to a normal FiO2. Now, if it is, let's see. Let me think about this for 1 second. If you develop hypoxemia because of an abnormally low venous oxygen, we're assuming that the person is that the alveolar oxygen. Let me tell you what I'm trying to do. The question was asked about whether I told you VQ mismatch causes an increased AA gradient. Intrapulmonary shunt causes an increased AA gradient. Hypoventilation does not. Abnormal diffusion does cause an increased gradient. Decreased FiO2 does not. So the question is, does this cause, is it associated with an increased AA gradient? So let me think about it out loud for a second. If this is 20, okay, and we're assuming that this number is not going to be 100. We're assuming that the person is hypoxemic. So let's say it's 80, okay? So we're assuming this number is 80. And we're changing nothing else except this number, and then we're given this number, told it's low. We're changing this one. This has to stay the same. All of these numbers have to stay the same. So when you calculate the AA gradient, it's going to be increased, isn't it? I think it's increased because the alveolar oxygen is going to be unchanged when you calculate the alveolar oxygen. So I think it probably would be associated with an increase in the AA gradient. But again, it's not really, the problem is not really with the alveolar capillary membrane. It's just with what you're starting with, okay? But I think that's true. But I probably won't ask you a question about that on the test if I'm not sure about the answer. So, but I think that's true. Does anybody know something about this that I don't? Anybody know? Anybody have any expertise in this area? All right. All right. Let's talk about asthma. Asthma is also a type of obstructive lung disease. It is the reversible obstructive lung disease. And so it can be brought out with provocative testing sometimes. They point out on page 39 that patients that have an asthmatic flare can develop pulsus paradoxus. Anybody remember the other condition that's associated with pulsus paradoxus? Cardiac tamponade. Cardiac tamponade. So this is another condition that can be associated with. I think we did reference that when we talked about the cardiac tamponade. And you remember the pathophysiology of that. You remember that it involves increased return of blood to the right side of the heart, and then bulging of this intraventricular septum to the left, so you get a decreased left-sided cardiac output during inspiration, and so you get a more than 10 millimeter drop in the blood pressure. Again, you need to remember that because, like for example, on the test, it would be fair to ask you, a patient comes in and the blood pressure drops by this much during inspiration. I might not say it's pulsus paradoxus. You're supposed to recognize that's pulsus paradoxus. What's the most likely explanation in this patient? And you should have to recognize. And you should also remember, okay, that you can also see it in cardiac tamponade. Okay, they point out that that the patients that have exacerbations of COPD or exacerbations of asthma, they have two pathologic processes that we try to attack pharmacologically or therapeutically. So you try and achieve bronchiolar dilatation, as illustrated in figure 2.3. Remember, the bronchioles are the site of the greatest resistance. I showed you that early in one of the first slides I showed you today. That's the site of the greatest resistance. That's why they're targeted with for example, beta agonists. And then there's also a component of inflammation, as depicted here. This shows you some of the inflammatory events that take place in asthma. And so these processes are going to be targeted as well. The parasympathetic, in figure 2.3, they reference the parasympathetic system, and they point out that the parasympathetic system tends to constrict the bronchioles. It also tends to increase bronchiolar secretions. And both of those things, constriction of the bronchioles and increased secretions, are going to tend to narrow the airway, and so you want to address both of those things. The anticholinergics, though, are used mostly in the treatment of COPD. They're not used so much in the treatment of asthma at all. They're used in the treatment of chronic obstructive pulmonary disease. And again, the targeting the inflammatory events is one of the indications for the use of the steroids in these patients. Okay. Cystic fibrosis is discussed on page 40. Cystic fibrosis is a cause of obstructive lung disease as well. It's caused by a genetic mutation. It affects the chloride transporter. It's inherited in autosomal recessive fashion. And the pathophysiology involves the production of viscous mucus that produces obstructive lung disease, but that also produces a pancreatic disease because of the viscosity of the pancreatic secretion. So patients can develop, pediatric patients can develop pancreatic insufficiency as well as lung disease. And let's see what okay, this shows you the targets, the lungs that are affected in patients that have cystic fibrosis. They mentioned that the diagnosis can be made with a chloride sweat test, and there is DNA testing is now available as well. You can actually look for the gene itself. Bronchiectasis is yet another type of obstructive lung disease. Bronchiectasis refers to abnormal dilatation of bronchi. And oftentimes, as you can see, this is a patient who has bronchiectasis post-tuberculosis. Okay, so bronchiectasis can be the result of an infectious disease that produces necrosis of lung tissue. You can see some of the dilatation of the bronchi. You see the huge air spaces there. So these patients, besides developing problems, you can imagine why they develop obstructive lung disease, because just as you see destruction of the interstitial tissue of the lung in emphysema, so you lose the tethering effect. The same thing's happening here on a different scale. These people are also prone to pooling of secretions, and that they can cough up some copious amounts of foul-smelling sputum. So, and that's going to be associated with the worsening of their disease. They can develop hemoptysis. So we've talked about a couple of different types of obstructive lung disease. We talked about emphysema, chronic bronchitis, asthma, bronchiectasis, cystic fibrosis. That's pretty much it. All right. Any questions about obstructive lung disease before we turn our attention to restrictive lung disease? So when you think about restrictive lung disease, look back at Figure 2.1, Panel C, and what you'll see is that you can develop a pattern consistent with restrictive lung disease for any of 3 different reasons. First of all, the patient can have a process that causes interstitial fibrosis, fibrotic lung disease. And they list a number of different causes of interstitial lung disease. They list pneumoconiosis, which is an occupational lung disease that's caused by dust inhalation. You can have a connective tissue disease such as scleroderma or progressive systemic sclerosis or lupus erythematosus. You can sometimes get sclerosing lung diseases from as a side effect of a drug, including amiodarone, which is notorious for that. And then you can have patients who have what's called idiopathic pulmonary fibrosis. They just develop pulmonary fibrosis. We don't know why they get it. Also, other diseases that we've talked about that can produce scarring in the lungs, sarcoidosis. Do you remember we talked about sarcoidosis when we talked about the heart? What does it do to the heart? What does sarcoidosis do to the heart? What does it do?
Infiltration.
Huh? No.
Constrictive.
Huh?
Inflammation.
Fibrotic tissue on the heart, right? Constriction.
No, it doesn't cause constrictive pericarditis. Yes.
It causes infiltrates it.
It causes granulomatous infiltration, and what does that cause? The restrictive cardiomyopathy. So it's going to present with, like, they can get diastolic dysfunction. Patients can develop ectopy. They can get, irritable focus in the heart. So they might develop PACs or PVCs or arrhythmias. But it can produce congestive heart failure as a result of diastolic dysfunction. Okay, that's the first category. Second category of restrictive lung disease includes diseases that produce abnormalities of the chest wall. And so they list a couple there, including kyphoscoliosis or ankylosing spondylitis or obesity. All of those things are going to tend to restrict the ability of the chest wall to move in and out. To the extent that you do that, the pattern that you get on pulmonary function tests is going to be one of restrictive pulmonary function. And then finally, the last thing is that you can get a restrictive lung disease picture in patients that have respiratory muscle weakness. And they list a couple of causes there, and these are things that we talked about. Remember when we talked about neurology, right? So we talked about Lou Gehrig's disease, ALS. We did talk about myasthenia gravis, spinal cord injury, multiple. We talked about, at least alluded to all of those things. So again, the stuff that we talked about in neurology now is coming back, and you need to be able to tie those things together. A couple of other notes of clarification. They talk about hypersensitivity pneumonitis. Okay, hypersensitivity pneumonitis, that's under stiff lungs, is an inflammatory process involving the alveoli caused by hypersensitivity to inhaled organic dusts. So these are things that you would maybe run into on a farm. This is something you'll see again in the pulmonary, or have you finished pulmonary already? Okay, so did you talk about the classification of the diffuse parenchymal lung diseases? Did you do this?
No.
Okay, well, so when somebody comes in, for example, with interstitial lung disease, okay, it could be it's a nightmare. It can be a whole bunch of things, And so how do you think about the person that comes in with scarring lung disease, okay? There's different classifications of it, but this is one of them, okay? You can have idiopathic interstitial pneumonia, you can have granulomatous processes, you can have sort of grab bag category associated with connective tissue disease. So it doesn't really matter which classification you like. It's just good for yourself to have a way to think about how do I generate in my own mind the differential diagnosis of this patient who's come in with interstitial lung disease, okay? And it's very complicated, but you just want to be able to think, at least in terms of broad categories. Let's see. Row. Okay, and this is, again, this is just for your own edification. It's not related to the pathophysiology so much, but it's just there to help you think about it. This lays out the approach of the patient. If you have a patient that has diffuse interstitial lung disease, how might you approach it diagnostically? And so it sort of lays it out in that algorithmic fashion. You might find that interesting or useful. Again, not everything that's on the slides is unless I tell you that you may need to know this. This is not something that I would likely ask you about because it's more diagnostic than path. It doesn't really illustrate the pathophysiology so much. I put it there for your own edification. Okay, now in terms of the pulmonary function tests in patients that have restrictive lung disease. Okay, here's the normal. We showed you obstructive lung disease. Here's the patient that has restrictive lung disease. Their volumes, the FVC, compared to normal, is decreased. Okay, so it's illustrated in figure 2.4 at the top of page 41. You can see a fall in both the FEV1 and the FVC, but the fall in the FVC, you see that is such that the ratio compared to the ratio of the FEV1 to the FVC is going to be greater in the patient that has restrictive lung disease. So the FEV1 to FVC ratio is either going to be maintained or is going to be increased compared to normal. Again, in the patient that has restrictive lung disease. So in obstructive, this is changing more. In restrictive, this is changing more. And that's why you see the changes, the different changes in the direction of the ratio. Again, when we talked about obstructive lung disease, we said that one way you can distinguish between patients that have predominantly emphysematous type of COPD and patients that have a predominantly bronchitic type of COPD is by looking at the diffusion capacity of carbon monoxide. You can also use that in patients that have restrictive lung disease to distinguish between patients that have a problem with pulmonary disease, intrinsic pulmonary disease, and patients, for example, that have a problem with the chest wall, or patients that have a problem with respiratory muscle weakness. Okay, you would not expect to see a change in the diffusion capacity if the disease is not in the lungs, but is in the chest wall or the respiratory muscles. You would expect to see a fall in the diffusion capacity if you're causing diffuse fibrosis that's going to interfere with that alveolar capillary membrane. So how else would you be able to distinguish between a problem with the lungs themselves or with the chest wall or respiratory muscles? Well, depending on the severity, I mean, they might be hypoventilating, depending on the severity of the disorder of the chest wall or respiratory muscles. Okay, and then again, this is just a little bit more sophisticated. This gives you an approach to interpreting pulmonary function tests. So you're going to end up at the end of this out, refers to an increase in pressure in the pulmonary vasculature. And what are some of the conditions that we talked about? What are some of the cardiac conditions that can be associated with an increase in pulmonary? Huh? Okay, so if you have left-sided congestive heart failure, right? If the left ventricle is affected, then you can develop pulmonary hypertension. Okay, and that could happen for a number of reasons. You can have diastolic dysfunction, you can have systolic dysfunction, you can have valvular disease like mitral stenosis, mitral regurgitation, you know, whatever. You know, a whole bunch of things can cause it. Okay, but as we said, oftentimes right heart failure is the result of left heart failure. It's the most common cause of right heart failure is left heart failure, but it doesn't have to be. Let's talk a little bit about some definitions, just so that you know about what's normal and what's not normal. Since we're saying that pulmonary hypertension is an increase in pressure, let's talk a little bit about normal pressures. So a normal pulmonary artery systolic blood pressure, this is the vessel that's coming out of the right ventricle, right? Normal pulmonary artery systolic blood pressure is 15 to 30 millimeters of mercury. A normal pulmonary artery mean blood pressure, a mean pulmonary artery blood pressure is 9 to 17 millimeters of mercury. A normal pulmonary artery diastolic blood pressure is 0 to 8. A normal pulmonary capillary wedge pressure, we talked about the wedge, remember when we talked about cardiac index and how to approach a patient with shock. Pulmonary capillary wedge pressure, normally 5 to 15. And a normal right atrial pressure is also the same as the central venous pressure, and that's 0 to 8 millimeters of mercury. By now you should know that a right atrial pressure, like I said, it's the same as a central venous pressure, and it's also the same as the right ventricular end diastolic pressure. Right? Central venous pressure, right atrial pressure is the same as a right ventricular end diastolic pressure. Okay, in terms of the things that can cause pulmonary hypertension, we talked about left heart causes of pulmonary hypertension. So you get heart failure and elevations of the pulmonary pressure as a result. The book talks about increases in flow from the right heart. Again, if you put an increased volume load on the right ventricle, ultimately what's going to happen is that if it's sustained long enough, and if it's high enough, you're going to see a rise in the pressure, and you'll see the development of pulmonary hypertension. You can also have intrinsic problems with the pulmonary vessels. So you can have, for example, primary pulmonary hypertension, and you can have certain vasculitides that are associated with pulmonary hypertension. Does anybody remember any of the vasculitides that we talked about that we said affect the lungs? See, now that's important to go back, because this is a little bit different than college, right? You have to be able to draw those connections between the stuff you studied last week or 2 weeks ago and the stuff you're studying now. You can't just flush it like you did in college, right? Because you're expected to remember a lot of that stuff. So remember we talked about, for example, we said that Church-Strauss can be associated with is a vasculitis that's associated with pulmonary disease. Remember any of the others? Huh?
Wagner's.
Say it loud. I'm
Wagner's.
yeah,
Wagner's.
Okay. All right. So then, yeah, there's a bunch of them. As a general rule, most pulmonary vasculitis is seen in small vessel vasculitides. Okay. You can sometimes or occasionally see pulmonary vasculitis associated with the large vessel vasculitides, and we talked about a few large vessel vasculitides. But it's unusual to have pulmonary vasculitis associated with the. It's rare that you see pulmonary vasculitis associated with a medium vessel vasculitis rather. So small is most common, large is next, and then medium is the least common. You can also have the development of pulmonary hypertension, as the book points out, because of that's secondary to interstitial lung disease. So if you get fibrosis, if you get widespread fibrosis of the lungs, that can distort the circulation of the lungs, and that can produce secondary hypertension as the fibrous tissue impinges on the lumens. And then lastly, you can get pulmonary hypertension that's the result of hypoxic vasoconstriction. Okay? And as you remember from physiology, the pulmonary vessels are the only vessels, I think, they're the only vessels that respond to hypoxia by constricting, right? All the other vessels respond to hypoxia by dilating, because if you have an area that's hypoxic, you want to get blood to it, okay? If you have an area, you want to get arterial blood to it, okay? You have a muscle that's hypoxic or whatever, you want to bring more blood to it, more blood, more oxygen, okay? So it makes sense from an evolutionary standpoint that the vessels would dilate, the systemic vessels would dilate in the face of hypoxia. But in the lungs, that's not what you want. Because if the lungs were to dilate, the lung vessels were to dilate in the face of hypoxia, let's say you're dealing with this. No, let's say you're dealing with this. Let's say you're dealing with this, okay? You don't want to send any blood at all to this alveolus, right? Because it's just wasted circulation, okay? It's wasted circulation. It's a shunt, okay? So, so you want this vessel to constrict in the face of hypoxia, and that's what the pulmonary vessels do. Now the problem is that's physiologic up to a point, right? To prevent blood flow to this alveolus. But what happens if all of the alveoli are like that? Or if enough of them are like this, that it causes an increase in the pulmonary pressure, then you get pulmonary hypertension secondary to the hypoxemia. So these people you have to treat by treating the hypoxemia, okay? And at a certain point in time, if you don't treat it, then you can develop. They give you a list of some of the common causes of sinusitis. Why is it helpful to know what some of the common causes of sinusitis are? I mean, from a practical standpoint.
Treat it correctly.
What's that?
Treat it correctly.
Yeah, so if you know what the most common causes of sinusitis are, and let's say you don't have a microbiological diagnosis of a culture result available to you, then you can treat empirically. And if you know what the most common organisms are, you make sure that your empiric treatment covers the common organisms. That's true not just of sinusitis, but pretty much of anything. Okay, we'll see that later on. One of the things that they don't mention about when they talk about sinusitis is is mucormycosis. Did you guys talk about mucormycosis in any other course? Patients that have uncontrolled diabetes, if you have a patient that has uncontrolled diabetes and they have anything to suggest a sinusitis, you need to be very concerned about it, very aggressive about it, because they might have a sinusitis that's the result of an organism called the mucor. It's also called zygomycosis, and it is an aggressive and really bad infection that patients can get. You can see that it's a basic. Oh. See, this is somebody that has lost a large chunk of his nose and face because of destruction of the sinuses and the sinus-related areas from mucormycosis. So you want to make sure that you don't miss. I think it's also called zygomycosis. Hold on a second. Let's see, we can see more images. That's a good one. Okay, you can see it's affecting the periorbital tissues there as well. That's the organism. Somebody that's had bad outcome. You can see a CT scan of somebody that's infected. You see, it can do real damage. So you don't want to. This is not. You see, it's eroded the palate. So you don't want to miss something like this. This is something that you got to get the infectious disease doctors and ENT involved in right away.
What's like the timeline for like how long it takes?
How long do they go from what?
Like you, I mean, like they get the infection.
I'm not sure. I think it's pretty aggressive. And again, the people that you worry about this in are uncontrolled diabetics, especially diabetics, let's say with ketoacidosis or something.
Is this fungal?
Yeah.
Oh.
It's a fungal infection, mucormycosis. I'm going to go. The last thing I'm going to talk about is I'm going to talk a little bit about pharyngitis, and then we'll pick up pulmonary next time, and then we'll go into renal. Okay. Okay, a couple of, just a clarification about nomenclature. When you talk about upper respiratory infection refers to infections of the upper respiratory tract. These are infections above the vocal cords, okay? So this would include, for example, tonsillitis, pharyngitis, laryngitis, sinusitis, otitis media, and the common cold. If it's below that, then we're talking about a lower respiratory infection. That would include bronchitis, obviously, and pneumonia. Bless you. Bless you. So let's talk about pharyngitis. Just to supplement a little bit about the discussion that the book has about pharyngitis. Obviously, what we're most concerned with, not exclusively, but we're predominantly concerned with, is group A streptococcus. We want to make sure to identify such patients and treat them early to prevent the development of sequelae such as acute rheumatic fever and post-streptococcal glomerulonephritis. Patients that are untreated can develop post-streptococcal glomerulonephritis or acute rheumatic fever. You also want to prevent any abscesses, prevent transmission to other people, and of course you want the patient to feel better too. They use these criteria called the CENTOR criteria, C-E-N-T-O-R. Did you talk about the CENTOR criteria? Did you have ENT?
Yeah.
Okay, did you talk about pharyngitis?
Oh, yeah.
Predicting like whether somebody that has pharyngitis has group A streptococcus or not? Did you talk about that?
That's not Jones criteria?
No, Jones criteria is for rheumatic fever.
Duke criteria?
That's
Duke?
hard.
I don't know. I know it was the central criteria. You tell me if these are the criteria that you would talk. Tonsillar exudates, tender tonsillar exudates, tender anterior cervical adenopathy, fever by history, and the absence of a cough. Have you heard those before? Okay, so we'll talk about them briefly, okay? If the patient has tonsillar exudates, or if they have tender anterior cervical adenopathy, or if they give a history of a fever, or if they say, I don't have a cough, okay? Those four criteria, to the extent that more of them are present, it increases the likelihood that they have group-based streptococcus. If they have a cough, if they have the absence, the reason the absence of a cough makes a difference is because if they have a cough, it increases the likelihood that they have something like a cold or something, all right? Which you wouldn't get with group-based streptococcus. So tonsillar exudates, tender anterior cervical adenopathy, fever by history, or the absence of a cough. Now the way the criteria work is as follows. If they have 0 or 1, they have less than a 3% chance of having a group-based streptococcus. If they have 4, if they have all 4, they have a greater than 40% chance of having group-based streptococcus. Okay? So generally, if the patient has less than 2, so they have 0 or if they have 0 or 1, generally you don't worry about the group A streptococcus. If they have all 4, oftentimes people will just treat empirically. Okay? The probability is high enough that you just say, okay, I'm going to treat empirically for it. I'm not going to do any more diagnostic testing. And then the diagnostic testing is often reserved for patients that have 2 or 3 of the Centaur criteria, because then their risk of group-based streptococcus is intermediate. And things you can do would include, for example, a throat culture, or you can do the rapid antibody testing for the rapid antibody test. What?
Do you take age into consideration?
Say what?
Do you take age into consideration for
Yeah.
the criteria?
I think you probably take it into you take a lot of things into consideration, including like how catastrophic it might be for this patient to develop the illness, if they have a history of traumatic fever or something like that. So you take a lot of things into consideration. I think it probably comes into consideration in terms of how risk averse you are and how likely you would be to not get tested, or how likely you would be to start empiric antibiotics while you're waiting for the results of the test, something like that. You do take it into consideration, but I don't think you take it into consideration. I don't think you take it into consideration in terms of applying the criteria. You just take it into consideration in terms of how you use the criteria. So again, just to summarize, bless you. What Up to Date says about the Centaur criteria is it says that again, the criteria have a higher negative than positive predictive value. They are most useful in identifying patients in whom neither microbiologic tests nor antimicrobial therapy are necessary. Okay. Patients with fewer than 2 Centaur criteria do not need to receive either antibiotic treatment or diagnostic testing. Most authorities now favor a sensitive, the assay, rapid streptococcal antigen test. They favor that. In adult patients with 2 or more Centaur criteria, okay? So you do the assay in patients that have 2 or more criteria. And again, you can make the argument that if they have 4 criteria, that a lot of people will go ahead and just treat empirically based on that. All right, I'm going to stop there. Next time we get together, we'll take it up with laryngitis, whatever, and then we'll start on the renal stuff. Does anybody have any questions about anything that we talked about today?